Good afternoon, everybody. I'm going to make a start. My computer tells me it's 1:30. I assume that's the right time. Welcome to the February Primary Care Commissioning Committee meeting. Seems a long time ago since I last saw you all, but then we didn't meet in January. Just a reminder that the meeting is recorded and it will be put on the website, the CCG website afterwards. Be joined by somebody from the EDP at some point. They have requested a link, so just a reminder to this is in public. I haven't done any chair's action, so I've got nothing to report. Under apologies, we've got apologies from Carl Gosling, Jude Bauer, and Thomas Iyer. On declarations of interest, just remind everybody to keep their updated, and Kathy had told me previously that she is conflicted under number 9, the Cqc report on East Norwich medical practice as a patient, and there is also a conflict for our clinical members and people who are employed in practice under the LCS. But as this is a public meeting, the papers have been shared. So I would just remind people to be mindful of any comments they wish to make. Moving on to the minutes of the last meeting, which was December. If we can remember that far back. Are any factual inaccuracies or arising that people want to bring up? Otherwise, I will take it as people happy to approve it. Don't see any hands, so we're happy for the minutes to be approved and signed, and we move swiftly onto the risk register. The agenda for today has been pared down to essential items, given where the NHS is in terms of workload with booster campaign and the level of demand within Norfolk and Waveney. So we're just essential items. So some items that we normally expect to see, like the forward planner, are not here today, just to streamline the meeting a bit. Onto the risk register. Sadie, can I? Oh, sorry, actually, this action log. I skipped past the action log very quickly. Everything is, there's 2 blue items which will come off, and then there are 3 amber items, which is 2 relates to the risk register, which I think we can cut in the risk register if they're still outstanding. And then there was just 1 item on around the High Street CQC report. I think there was John had asked a question, and there was going to be some link up outside the meeting. So can that one be closed, John?
I don't recall seeing anything on that, Doris, but Sadie's got a hand up. I don't know if it's in relation to that point. I did check earlier.
Sadie?
I didn't recall anything from Carl.
Thank you. So with regards to the first 2 items, they have both been dealt with and closed. I've linked in with the quality team on Action 90, and hopefully on 91 you'll see in the pack that it's been updated following a discussion with Mark. On Action 92, an email was circulated offline to members detailing the action plan. We can resend that, John, if something's happened with that in your inbox, but hopefully you'll have all seen what the practice is focusing on, and very happy that we can discuss that further in the confidential part of the meeting if people have any remaining concerns.
That was great. Thank you, Sadie. So I think we can close that one off unless something else pops up later on today. Great. So everything on the action log is closed, unless we add more things this afternoon. Moving swiftly on to the risk register then. Sadie, do you want to just highlight anything before we open to questions?
Thank you very much. So just as usual, just going to focus on the highest risks and any changes for this month. So if I can just draw your attention and not go into too much detail, so because we've got this later on the agenda. PC3 is the LCS risk. That is likely to reduce next month and potentially move towards recommendation of closure, but we will see how the next few weeks goes, and obviously Gina will update more on that through the agenda item. PC6 is learning disability health checks. That's a red risk, but it is on the agenda for later, so propose that we can pick up any new actions as part of that item. PC8 is the cost pressures in the medicines budget line. You'll see on the update that that is recommended to close. There is a slight anomaly there in the scoring. That the scoring this month, apologies for the oversight, should have been updated to 9, which is the recommended target score. And Michael is proposing that the cost pressures are monitored through the monthly prescribing report, which normally comes to committee. You'll notice that it's not on committee today, in line with what Doris just said. So hopefully everybody's happy with that. PC9 is the hypnotics and anxiolytics. Whilst that is an improving picture, there's a nationally improving picture. So our position as the third worst hasn't changed, albeit that things are improving. PC11 is the interface risk. You'll see an update there around both the interface policy and the access policy. There have been ongoing discussions around that in between meetings, and it has been decided that both of those items will go back to the next interface meeting, which Mark chairs for full discussion. And we'll update on that with a formal report as per the frequency that Lois agreed with members last time she brought paper. And then finally is PC14, which is the GBAF 07 from our action log. Many of the issues previously raised around testing, etc., are settling. However, the urgent activity and the workload associated with recovery continues in primary care just as much as it does for everybody else in the system. And of course, at the same time, we continue to hear about pressures caused by staffing, either people who are testing positive or who are isolating, and unfortunately it's no different in general practice as it is everywhere else. So I think it's still very strongly being felt there. The good news as part of that is that practices are now really focusing on drawing down the additional resources open to them through the Winter Access Fund, and we have seen an uptick in that plan and the implementation of it, and therefore the associated claims. So I think that is very welcome to general practice in the system at the moment. So that was all I was going to say by way of covering off the risk register, but obviously colleagues and I are very happy to take any questions or comments. Thank you.
Thank you, Sadie, for that summary. Are there any questions, comments for Sadie on the risk register? Tracy?
Yeah, thank you, Sadie. So sort of relating to some of the pressures and the recovery in primary care, just going back to PC1 in respect to general practice workforce. So I can see that has been updated for January, but just wondering, you know, what the impact might be on staff choosing to leave, staff choosing to retire, and kind of workforce generally, because just from my anecdotal kind of experiences, I am seeing staff retiring earlier than we would anticipate it. I am seeing challenges for staff in primary care. So just wondering if that might be something we want to revisit again and just do a stock take with where those kind of forecasts are for staffing levels across the system in respect to primary care staff.
Thanks, Tracy. I think that's a very well made point. And in fact, we were talking about that very thing yesterday in terms of our aspirations for workforce planning now that our staff have come back from being redeployed. We're back into the planning round again in terms of the operational plans for the CCG as well, and that forms a very clear part of our commitments for next year. May I just ask if there's anything additional that Fiona would like to add as the workforce lead for us in the team?
Thank you, Sadie. Yes, and I think it's a point well made, and we recognise that. We are looking at the GP retention and recruitment strategy and refreshing that. We've just started to look at that, but obviously we need to refresh it in the context of a multidisciplinary team approach since the last time it was produced, but obviously mindful of the fact that yes, we may well see early retirements, and so retention has got to be a big piece of the work that we do this year, and as part of that, obviously we'll be working closely with the ICS workforce team as well, to bring their expertise into that planning process, and that's also part of us working closer together with them.
Thank you. Hope that answers your question, Tracy. John?
Yeah, thank you. Just a couple of points. One was PC11, which was the interface risk. It's still down as very high risk 16, but wasn't quite clear what the current gaps are in controls, I suppose, in terms of the language on the forms that's driving that particularly high risk. And then the other comment I was going to make was PC15, I think it is, the estates one. I know that it's been escalated to me recently that there's some growing concern about the timescales around the processes involved with the Wave 4B primary care hubs that I'm escalating with the regional team. So it feels like the risk on PC15 has grown actually.
Okay.
Paul, I will obviously be able to provide more background.
Yeah. So I will pick up with Paul on PC15, John, outside of the meeting, and ask him just to have a look at the risk score. I can see Mark hovering in terms of the interface risk.
Yeah, so thanks, Eddie. And John, if I may come in now. So yes, so we're making good progress with that, with the interface group, John, but there's still a lot to be agreed. And it's a bit of a case of one or two steps forward and maybe one or two back at times around reaching agreement, particularly across the three acutes. You know, genuine concerns being raised by all sides. So, you know, we are reaching agreement in a number of areas, but there's still some work to do before I think we can, you know, say with confidence we've reduced a lot of the risk. So I'm hoping in the next month to 2 months we'll make some progress on this, but there's some quite in-depth conversations happening both in the meeting itself and outside to try and make progress.
Thank you. I would echo John's comments about the estates risk. Just from the narrative, the risk level seems a bit low to me. Are we all happy to take off the proposed that Michael's proposing to take off the risk register, the cost pressure of the risk map? Yep, great. Thank you very much. No further questions. I will move on to the paper on locally commissioned service. Are you taking this one, Sadie, or is Gina joining us?
I think Gina is going to join us if she's not here already.
I'm probably a bit ahead of time. That's the problem. I
You
think
probably are.
I'll try and
Just dialing her.
Shall we take the resilience funding process first, and then when Gina joins us, we'll come back, seeing Shepherd's with us, I think. Gina's joined us. Great, thank you. Sorry, Gina, I'm running ahead of time, just to confuse you. Thank you for joining us, and an update on the locally commissioned service.
Apologies, this is very unprofessional. I actually pulled my paper up. I wasn't quite ready. Bear me 2 seconds.
Sorry, we jumped the gun and got you on the hop.
That's fine. That's right. I'm here now. Right. So yes, thank you. Paper as came out after last week with regards to the position on the LCS review. I think that the work undertaken by the team in the lead up to the launch has been phenomenal, so that we met the deadline we had of ourselves on the 6th of January to issue the launch pack to all practices for the 12 LCSs that we wanted to go out with, and the decommissioning of the previous 38 that came through. The specifications went out on time, along with a notification around engagement events that we'd offered to undertake in order to ensure that the information and the transparency was there with regards to the process and the content. We also undertook a large number of practice meetings, practice manager meetings, GP meetings. I think we did something like 30 meetings in 2.5 weeks in order to be able to launch properly the pack going out. So of the 12 LCSs and of the 105 practices we have, we've had 100 sign up to date. The other 5 have all had agreed extensions. And of those, I'm very, very pleased to say majority of practices have signed up to all the services that are offered. So across the board, we have, I think, met the brief from that perspective. With regards to kind of the themes that are coming back with regards to the engagement events and the concerns from practices, I think a majority of it was having to transition their thinking around the way that they were offering their current services and how we are moving forward. It's a bit of a step change for us to only be asking to commission the services that are currently looking at and that are being funded. And I think that some of the themes that we had coming through were practices feeling that they weren't necessarily wanting to give up the things they were doing previously, and then needing to kind of step change from how we're looking to support individual patients across to supporting the patients across Norfolk and Waveney. And there was a bit of a mindset change, the realisation that we needed to ensure that all patients across all practices were able to access the same services in order to bring Norfolk and Waveney into the position that we wanted it to do so. And that's one of the 6 key principles we had started with in order to make this fair to everybody. They were very grateful for the process put in with regards to reporting and the clear navigation of what they need to do, the funding streams that are going to be coming through, how it's been calculated, and the reduction in bureaucracy has all been accepted and very pleased about. With regards to next steps and where we are currently, we have a couple of practices that we had agreed an extension to deadline for individual reasons which were outside of the norm, which weren't to be expected. We have 2 service lines that we are looking to go back to those practices who've decided not to sign up to them. I think one we have 6 practices have decided not to go through, and the other one I think has got 8 practices to understand the concerns around offering their services. One of them I know is linked directly to the pandemic and additional IPC requirements. So we have a meeting taking place this week, and that's to do with spirometry and aerosol general operated procedures, to kind of work across practices and across the infection prevention and control team to mitigate any concerns around that. And then we should revisit those who haven't decided whether or not they don't want to sign up. And then the other one, we are working, it's the eating disorders, which we kind of thought may cause concerns because we've always had a problem rolling it out across the county. We have our mental health commissioners and connected specialist GPs talking to those practices who've decided not to sign up at this stage to again understand their concerns. And that's the process we're taking with all of them before we go out to look at how else we can provide that service, to be able to ensure that decisions are made on full and fair basis of understanding rather than on perceptions or misconceptions. So that's kind of the remainder to do for the rest of this month, is to ensure that we have services available to everybody. We are going to go through and start working to raise the contracts for those specifications for those who've signed up. And then we're into kind of mobilisation of ongoing contractual and financial management of how we're going to manage these contracts going forward. So I'm sorry that's a bit of a rattle through of the paper. I'm kind of hoping everybody's read the paper previously, and apologies for being on the hop at the beginning. Any questions?
I think it's poor chairing skills that I need to slow down at the beginning. That's I'm too pumped up with caffeine right at the beginning. I think actually, given the pressures that you've all been working under, you know, you've come to landed us in a really good place that most practices have signed up. And, you know, once again, thank you to you and your team, and also the LMC for their support as well. We wouldn't have got there without collegiate working. Andrew.
Yeah, thank you. Hello, Gina. Just a quick question really to ask. I mean, I was really, having read all the papers, really impressed with the detail, and it's all brilliant. But what's the part of the plan that involves communicating these changes to the public? Because I'm sure people want to know, if any changes take place, how it impinges on their personal care.
Thanks, Andrew. That's a very valid question. It's something that we're currently working with our comms team on in order to get a comprehensive plan in place. Majority of them are a kind of a change in pathway rather than a change in service provision. So a majority of the elements that have either been decommissioned is because we have alternative services already in place, and therefore we'll ensure that every practice has a very clear pathway about how they access the alternative provision. And then for those where there's a slightly more fundamental change to what we're commissioning, we are going to ensure that there is a comprehensive plan for patients and for practices to have. And we're currently literally we're meeting tomorrow morning, I think, with regards to our comms team to start working that one through. So what we want to absolutely be sure of is that patients aren't left wondering what's going on and how do I do this and why. It'll be a case of, right, this is what you need to do, or as a result of clinical decision making, this is what's going to happen next. So that's kind of the next phase really, but we are underway, and hopefully by next PCCC I'll have an articulation for you that's slightly more rounded. Great,
thanks. I'm sure it wasn't forgotten, I know.
No, it wasn't. It was just workload of kind of trying to say, right, yeah, once we know, because if practices hadn't decided to sign up, the message we'd have to patients of how they access services will be different to that than if they are all signing up. So that's why we didn't want to work it up in advance, so that we weren't working it up on a two basis prong. It's kind of right, let's see where we are, and we know what we've got, then we can work it through how we convey that. Thank you.
John?
Yeah, thanks, Doris. Sounds like tremendous progress, so really well done again to Gina and everybody that's been involved with this. My question is similarly around the decommissioned services, because I know that there's been some maybe partial information being shared with providers, for instance, which they set hairs running unnecessarily. And just linking that, I suppose, two questions. One is, I believe there were some comms that were going out to local providers and GP provider organisations just to confirm the basis of the work that was being done and the services that were being decommissioned. And also in the paper, it refers to the equality impact assessments and the quality impact assessments for decommissioned services. Can we just have assurance that there was nothing flagged by those assessments that we need to be conscious of today?
Thanks, John. So yeah, so on the first point, Mark and Sadie wrote to all the providers, and that letter I think went out 2 weeks ago. I'm just looking for not at least a week, 10 days ago. Yeah. So they are all aware of it, and we've had communications with some of them since then, both community providers and GPPOs. So we know that it's landed and been received, and they are supportive. With regards to the EIAs and QIAs, they have all been undertaken. The only aspects I think is worth voicing is that in order to achieve equity across the board and equalisation of services, there are pockets of really good initiatives that have been happening that we've had to stand down as far as funding lines go. But we've been working really hard with those practices to enable them to deliver the essence of the same initiatives and projects through their proactive healthcare timeline. So on paper, it looks as though it could be a detrimental impact, but in actuality, because we're working so closely with them and enabling them to deliver the pockets of really good practice we've had across the county, but in a way that enables it to be delivered on an equalised basis along the same fundamental principles. That means that every patient is able to benefit from that additional service, even though those additional services might be slightly different. So I think that's the kind of key bit to the flag that's been come up with the impact assessments, but they are currently being rubber stamped by the quality team. So we'll have them back very soon, but they are all in our system if needed.
Thank you.
Are there any other questions for Gina? No. Thank you, Gina. I'm sure we will see you again before too long, and keep it going. Keep smiling.
Thank you very much.
That's great. Thank you. Right, on to the resilience funding process. I think, Shepherd, are you taking us through this?
Thank you, Doris, and good afternoon to everyone. I'm really pleased to talk about the hard work that has gone into the resilience funding process and the outcome for this year's funding allocation. So there are two parts to this paper that is before you. The first part of it is actually the process for resilience funding, which members may recall from the previous meeting that we did talk about the tier audit findings that we were addressing as commissioners. And I'm really pleased that a lot of good work has gone into there. You've got the areas that were identified in the audit report, and you've got the responses that we have set out in the report. So I don't intend to go into that. But the test obviously is we have now run this year's funding panels, and we have successfully allocated some funding to a number of practices and PCN. And clearly, we have seen an improvement from the previous year. This year, we've received just under 40 applications compared to 8 applications in the previous year. Certainly, the improvements are visible in this. So members are being asked to note the progress that is highlighted in the report, and also the outcomes of the funding allocations for this year, and also an indication of our plans of an early start for the following year. I will stop there and take any questions from members.
Thank you, Shepherd. It's good to see that planning is, in place for next year rather than last minute towards the end of the year, so we can spread it out a bit, which is great news. Kathy.
Thanks, and thank you for the report. Very helpful. One really idiot question, which is, what on earth do they spend it on? I mean, well, it's a relatively small amount of money. I mean, what is there that can support practices to increase their resilience? And the second question is there any risk that this process increases the inequalities between practices? I'm just thinking that if you have a fairly robust infrastructure in a practice, you can apply for a bidding process, which is fairly comprehensive, whereas if you don't, i.e. you're not resilient, you may not be able to access the funding. So those were my two questions. Thank you.
Thank you, Kathy. Really good questions to challenge us to continue to improve. So if I start the first questions, which is actually, what is this money being used for? We have been interested, and we have met with all the practices actually to talk about the bids that they've submitted, and the themes that have come through in that. Training for staff is one of the main area that has come through. Some of it is actually to cover sicknesses. The other areas which obviously did not meet here, but have been signposted to other areas, some wanted to improve the environment that they have, and through this process we've linked with the other funding pots through the estate team. Some are to do with technology. Some practices wanted to embrace technology and do more in that, and we've connected with the digital team and linked that. Yeah, I think just to highlight a few, but it's very interesting. There will be a report to summarize, to share with the practices across in terms of what we have found out and what we have allocated money to. So it will be really interesting. I will be looking forward probably to share that in more detail. Really good questions. I would appreciate. Then in terms of inequalities, that's again a good question and a good challenge for us. We were challenged before through the tier process and LMC colleagues to say, actually, what we've noticed over the years is those practices that have got the capability to write and the time are the ones that are likely to make the submissions. But I would say, I think we need to note the improvements that we've had this year compared to last year. From 8 applications last year to 39 applications this year. And that was due to a lot of communication, a lot of interest from the commissioning team to reach out to the practices that have not applied before, and also that we know from the work that we do every day that may need that support. We triangulated almost all the work that we do to link with the resilience funding, and we'll continue to do that. I've got no doubt that with our interest in inequalities, we'll find out more and we'll work to improve our strength in addressing inequalities. We've got huge interest in LD and SMI as areas that we have not performed well. So we are triangulating almost everything into the resources that we have. I'll be interested if there are any other areas that members think we need to test on.
Thank you, Shepherd. Naomi.
Hi, yes, thank you. First, I just wanted to say thank you to the CSG team, because I think the process this year has been really robust and their input has been really extensive and supportive to practices and in the process itself. So thank you for that. And also building on Kathy's point, it is a concern the LMC has raised around the resilience funding and the process, and ensuring that we're making it as easily accessible for all practices, because it's right that those that don't have the capacity and that are really struggling are probably in most need of this funding, but may well not have the resource in place to actually apply for it. So that was all part of the initial discussions around how to make this funding accessible. And certainly some of the learning points from this year have been around increasing sharing what has previously been a successful bid, so that it can share ideas with other practices that may not have thought of things, so they can consider whether that might work for them. There's also a couple of things that have been agreed as short-term, almost pilots, so that if they work really well, again, that can be something that could be more extensively rolled out. And also trying to improve the input to practices to support them putting in bids. So fully agree with what Kathy said, and certainly agree they are outcomes to keep on learning based on each year and how it can improve, and certainly think that is the focus for next year from our point of view, and it seems the CCGs as well.
Thank you, Naomi. Tracy?
Yeah, thank you. Really good to hear about the kind of the process in place and the fact that will give that equal opportunity for all practices, certainly those that are less resistant, to be able to apply for some of the funding as well. Just noting that it was a recommendation from TIA, so will TIA respect that kind of that loop to be closed and to have some feedback from what the process is kind of moved on to be, and that it's a different process? Just wondering about that, and also just thinking about the opportunities to link some of the resilience funding to further health inequalities, sort of work of the oversight group as we plan going forwards in the system, because certainly perhaps some of those deep end practices, those practices less resilient, will be in areas of deprivation. So that as a system we can kind of link with many other initiatives that are going on to ensure we do address some of those health inequalities. So I think there might be opportunities to link many things.
Thank you, Tracy. I think because the TIA report would have gone through audit committee, and they will be monitoring closing off any actions on that one rather than duplicate their efforts. And I'm sure Shep has taken on board the other suggestions in terms of improving access and addressing inequalities as well. I just had a question about analysing the impact of previous funding rounds, and whether, you know, there could be a summary at some point to come back to go, you know, we funded this and it met its objective, and do the same thing for this year, so that we have some learning from it, rather the money's gone out and we don't go back and go, was that really, you know, an effective way of using the money to support practice?
Absolutely. It is our commitment to do that, and also with some background work is already underway to capture that, and some practices are really keen to share the hard work that, or the benefits they've got from previous funding. So yes.
Great, thank you. There's no other questions. I will move on and probably catch more people on the hop because I'm half an hour ahead. Can I suggest that we do the CQC reports first and then come back to the diabetes recovery to give people a bit more time to catch up with us?
Okay, I think it's me again. If it's the CQC report, I'll probably just need to open those reports to start with. Perhaps I could just start and give, we've got 3 practices or 3 reports since the last time we met that have come through from CQC, and it's for 3 practices. I don't intend to spend more time on the 2, but I would like to make a comment on those 2, then move to the 3rd one, which I'm sure the members will be more interested to have a discussion on. So the report we have, it's for East Norwich Medical Practice and the parish fields and Thorpewood. So really well done to the practices, East Norwich Medical Practice and the parish, for achieving a good rating with CQC. And I don't underestimate the amount of work that goes from those teams to be able to reach that. So I will stop there on those 2 and pause for a second if colleagues have got any comments on those before probably I go on to Thorpewood.
No, it's really good to see some green ratings coming through rather than doom and gloom all the time. So we need to celebrate achievements, good achievements. So that's really good to see. Thank you, Hein.
Yeah, no, indeed, good to see. It was also interesting to read how much the upgrade of the telephone software system in East Norwich has helped them to improve service quality. So that's something to keep in mind as we hope more and more practices update their communication systems. Thanks.
Okay. So Thorpewood was inspected last year, and the report, they've been rated as requires improvement in a number of areas. And I think I need to highlight that whilst they require improvement, again this time, there are some improvements that have been done from requires improvement to good. So clearly some work has been going on in the background to try and improve. But the number of areas that have been highlighted include around safe management of medicines, patient satisfaction surveys, around governance, around their ability to respond, screening, and areas around documentation and around the safety alerts. And I can confirm that there is an action plan that has been agreed by CQC, and also that has been shared with the CCG. And CQC, we met with CQC this week, and they have confirmed that they are assured about the work that is being carried out by the practice. And they have asked us as a system to approach this with balance to allow the clinical teams to support the practice to continue to do the improvements. Our medicines management team is engaged in this, and also our quality management team are involved. There are regular meetings with the commissioning team and all the key stakeholders to review progress every 2 months now. I will stop there and request any response, comments, or feedback from the members.
Are there any questions for Shepherd? John?
Just a couple of points, actually. One is, my perception is that when we get CQC reports that are maybe lower ratings than good, they're quite often medicines issues involved. And I just wonder what processes we have for sharing learning, I suppose, from practices where we do have things to improve, what process we have for sharing that learning across all practices. And the other question I was going to raise actually was a broader one of context. That my understanding in the past has been that actually general practice in Norfolk and Waveney is very good and rates well generally on CQC. I know we quite rightly focus on those that are requires improvement or have lower ratings, but actually I think it'd be useful every now and then just to get that broader context of actually where our practices are compared to, for instance, a national average, just so that we have that sense of balance, I suppose.
Yeah, absolutely. In terms of learning, I think, well, my view about learning, it should be part and parcel of our everyday interactions. But I think going forward, I would like to work with the team to have a more structured way of sharing the learning, and it's starting to develop in the team. So I would like to come back to that in terms of to take some time to think about how are we going to take a more structured learning across the system, taking into account what already exists now, and how we can improve that going forward. I can see Michael may have some answers because it's medicines.
Yeah, I can pick that up, Shepherd. Well, we have prescribing leads meetings have now started again, and the first item on the agenda is Mhra Updates, which is usually some of the issues that some practices are picked up on. You know, just being able to evidence that they've reviewed the safety warnings and looked at all the patients, and evidence of what they've done with the patients clearly recorded in the notes. And if there are any themes that the CSU team, who mostly do the practice work, bring to us, then we do put that on the agenda. So it's very much that these are the safety alerts, and that, you know, as you know, CQC will expect to see some evidence that they've been actioned. So there is a reminder for practices at every meeting, which are now every 2 months. Yeah, but if we want to do anything more structured, Shepherd, perhaps we can have a conversation offline. That would I'd quite happily engage with that process.
Sadie, did you want to come in?
I was just going to add to what both Shepherd and Michael have already said. We did do a series of webinars for practices on the CQC searches and things like that, and what learning came from some of the work we'd done with some other practices. They were all recorded, and shared with practices. And Tracy Rogers, who comes to this committee, she was instrumental in working on those as well. Now it might be that they need to be refreshed because the Cqc are looking at different things, but certainly we can remind practices that they're still there and make sure that they're circulated again. But I think it's a really sensible idea to keep refreshing things like that, because certainly, you know, the guidance moves on and the inspection regime changes slightly. So we will have a look at that. Thank you.
Chris?
Thank you. Yeah, just to come in there on Sadie's point, I think that's a really valid point, and I think probably as looking at what John's comment is, some of those key themes we could probably then look to prioritise where we might want to focus our attentions, or have dedicated sessions on what we're pulling out as the key themes from some of these reports, so we can certainly take that offline and look into that.
That's great, thank you. Any other comments, questions? Michael, I assume that's a legacy hand rather than I assume it is. That's great. Thank you very much for that update, Shepherd. And I mean, it is good that they have made some improvements. Obviously, more work needs to be done to get them to be a good practice. So keep up the work with them. I will move on. I think Claire's not with us yet. I'm going to do a bit more juggling. Health check reports. I think Julian was going to, he's not here. Shepherd, you're here, so you get drawn the short straw. Do you want to just talk us through the learning disability report, and then we'll do a bit of I have to remember what I've done and what I haven't done.
Okay, thank you for that, Doris. I will take you the LD annual health checks report. Then hopefully Julian by then would have joined us. Okay, so for learning disabilities, we are now in quarter. Where are we? We are now in quarter four. I mean, yeah, almost the end of the year now. But obviously our reporting there's a lag time in reporting, so we are still reporting end of December. I would like the members to note that we've made progress, and we continue to make progress, and we are sitting just about 40%, and we are just encroaching above other regions within our region, other systems in our region. So we are making very good progress compared to last month. And it's also encouraging to see that going forward, we are going to perform better. I think things to highlight, I think for this meeting is we've invested more resources to actually carry out some reviews, and those resources are targeted in the West locality. So far, we have 3 qualified nurses that are being hosted by Fens and Breaks, PCN, to actually work with individual practices to be able to carry out the review. So it's going to be a busy month, this month and the following month. And alongside that, there are other medium-term arrangements that are being put in place. So Protect Now is, we are engaging with Protect Now to agree on their support with the annual health checks in terms of contact, in terms of data. It's really beautiful to see the capability that sits with Protect Now that we have not used before. So I'm really looking forward taking that work forward. And also there are beautiful plans that are emerging from the West locality, working with the community hospital and also the mental health trust to try and change the the configuration of how we deliver our services for the long term. So I'm really looking forward to see those improvements actually making an impact. I will stop there and probably ask for some reactions or comments from colleagues, but I feel encouraged with the work that the teams are doing at the moment.
Thank you, Shepherd. Are there any questions for Shepherd? Tracy.
Thank you, Shepherd. It is great to see the process, and certainly when we know primary care has been under extreme pressure, and I do think the added addition of Protect Norfolk and Waveney just getting to the crux of the data is one aspect, but it certainly is reaching communities and community connection and champions, supporting people to uptake those health checks was important. So interested in our approach to kind of put some resource into nurses doing the health checks for now, but I think we've got to think about the longer term, and it's all happening in this kind of last quarter, but certainly how do we spread that during, you know, the whole year, and how do we kind of resource those kind of nurses or whichever healthcare professionals are doing them to do that in the longer term. So we've got more of a rolling kind of targeted approach, and that really is quite holistic in its approach. I think there's some work we can do there, really, certainly think about health inequalities and addressing those.
Thanks, Tracy. John?
Just like to support what Tracy said there, I know clearly this is a difficult service to deliver in terms of the expectations that we have, and the last couple of years have clearly been very, very difficult given everything else that's been going on, but it always seems to be a challenge at the end of the year to try to get up to the target, which feels like, as Tracy said, we're not planning it maybe as well as we could do throughout the year, and that's, you know, coming from a position of ignorance in terms of not necessarily knowing what's involved and how practices will go about scheduling this, but it does feel like we need a different approach, I think, that does have this as a more sustainable service across the year. And question, is it something that practices can deliver? Because we always seem to struggle to get to the target, and it's not about the target, is it? It's about the patients who are a very vulnerable group of patients that we do need to make sure get seen. And I'm also struck by the fact the numbers are relatively low, because I like numbers. I had a little play earlier, and to hit the 75%, it would mean 2 health checks per practice per week, which again, in those terms, doesn't seem a huge amount, but I don't know if a health check takes a day or a half day, and therefore it's quite time consuming. But whatever it is, it feels like we need a more robust, sustainable plan for this. And I know we've talked before about what is the plan, what's the trajectory, and what are the actions that are taking place between now and 31st of March to say that we know that another 200, 500 patients will receive a check. It doesn't feel like we've got that tangible sense of what's actually going to happen, I think, to make a difference for these patients.
Do you want to respond, Shepherd?
Yes, absolutely, and I share and I accept the observations and comment. I think I did say before, it's not a straight line. There's quite a lot that is involved in there. So whilst the numbers are showing low today, but it doesn't mean that all the data has been submitted, because I think there's a huge interest from the practices, because this is also incentivized. So coming to the end of the year, they will be wanting to close that. So we are likely to see a percentage of improvement that is related to data. And we are also going to see an improvement that is related to actually the usual practice that practices have always done, to do the work last minute. And so whilst the numbers look low today, I don't think they will be low at the end. But I think we have a risk that with the booster program, the vaccination program, the resources were diverted, and to actually work out how or the impact of that diversion is very difficult at the moment. But what I know, and the feedback I've received from one of the practices, is we're hoping that we will land our numbers, but I think we are not likely to do as well as we wanted because we diverted the resources. That is a direct feedback from the practice. So they've asked for additional resources, which we are providing. So I'm afraid it's going to be waiting to pull together different strands of data coding and everything into the system, and then also working through the reviews, then upload them into the system, then we'll know the final position that we have. The focus now is for us to now get a strong start for the Q1 to change the way we've done things before. And I'm hoping that the conversations that we've started having to actually kickstart the next year at the beginning rather than in the middle will help us actually to start shaping and to be able to answer the questions that you've posed today about what is the plan. So we are going to be working hand in hand with the practices from Q1 to be able to answer those questions. So I'm looking forward to the committee meetings in Q1 now as we close this year.
We will remember that, Shepherd. Well, yes, I'm pleased that you're hopeful, but I suppose we just have to watch the space, and it would be good to see these checks, you know, spread out more during the year. And I know there's that move to, you know, do it by birthdays rather than so it will naturally spread things out a wee bit that way, which will help. Kathy.
Thanks, and thanks, Shepherd. I'm just again reflecting back to when we started talking about this issue in this committee. We didn't know what the data said, and we didn't know where we were. So I think, you know, tribute to how much work has been done to find out where we are, and tribute to, you know, the work that has been done. That means we might meet a target, even though that target is not sufficiently ambitious in my view. I guess my reflection is that it seems that we're beginning to maybe ask the wrong question, which is not have we completed our health checks, but what difference have we made to this population, and how do we enable a system that is sustainable and actually has a well-built learning loop so that we can reduce inequalities in the specific group, because the inequalities are enormous, aren't they? This group dies much younger than any other, you know, most other group that we have in the population we serve. And I guess a word of warning for me is that, you know, I've been around far too long, and I've seen this service invested in and then disinvested in, and then it gets taken into general services, and then we suddenly realise that we've had a terrible tragedy, and then we invest in it again. So how can we stop that limping from crisis to crisis and make this a genuine mainstream service going forward? Thank you.
If I may respond to that, what I'm looking for is learning disabilities and other inequality service lines to be visible in our structures. So the only way I would see is that when ownership is sitting at every stages of our governance structures around this program. And as it stands, I know there's huge interest. Obviously, John's interest is visible every time in here. And I know Kath is actually very interested in this, and we've got more meetings. If there's a work stream that I'm spending more time talking about and seeing in almost every paper that is coming through, it's learning disabilities and also SMI. And just to say, I've seen through the winter funds, I've seen learning disabilities actually being visible in there. And I think at every opportunity, the test is for us to see where it's not being visible than where it is visible for me.
Thank you, Shepherd, for stepping in to help me do my time management. I noticed Claire and Chris has now joined us at the correct time because there's very poor chairing, so we have to juggle the agenda around a bit. Welcome, Claire and Chris. We'll move back to the diabetes recovery paper.
Thank you, and that seems to me that it segues perfectly from Shepherd, what Shepherd has just been saying about people living with learning disability and SMI. Yes, they suffer enormous risk of premature mortality, largely contributed to by cardiometabolic disease, amongst other things. bearing that in mind, cardiometabolic disease is a hugely important area. Just before we start, Doris, if I may, because I don't think I was sent a copy of the agenda, can I just check what time you've allowed for it, just so that helps me in terms of how I present?
You've got 10 minutes, but I'm actually overrunning. I'm sorry, I'm way ahead of time. So I will let you have a bit more if you need it.
Lovely, thank you. I will take the paper as read, just because I think there are a few people on the call who may not know me. So just by way of background, my name's Claire Hambling. I'm a general practitioner, obviously working in Norfolk and Waveney. I have an interest in diabetes. I'm the GP clinical lead for diabetes for Norfolk and Waveney. I'm also the chair of the Primary Care Diabetes Network, and as a consequence, I'm very well networked with our system nationally, including at the weekly or monthly network calls with the National Clinical Director, and obviously lead our engagement with the East of England CVD network. Just by way of background for the paper, we were given an opportunity to bid for some NHS England recovery funding for diabetes. So in order to prepare or think about what we might do if we were going to make that bid, I met with a number of my GP colleagues, or primary care colleagues, I should say, multidisciplinary team from across the whole of Norfolk and Waveney, to find out what their concerns were regarding diabetes and diabetes recovery. And so that helped us inform the bid that went to NHS England. And as you can see from the paper, we were successful. The maximum we could bid for was £125,000. We were awarded that full £125,000 to help restore diabetes care. So we're very pleased to receive that. Many of you will also know that routine care is an explicit part of the system oversight framework, including in particular diabetes and delivery of diabetes care in primary care. Prior to the pandemic, we were a system that was challenged in delivering that as well as we wanted to, but we were actually making some progress across the whole patch. And then, of course, that improvement piece has been massively impacted by the arrival of the coronavirus pandemic. People with diabetes have been particularly affected for a multitude of different reasons. Firstly, by COVID itself. People with diabetes who catch coronavirus are significantly more likely than others to require hospitalisation, ITU admission, and indeed face significantly higher mortality. In the first wave of coronavirus, 2 to 3 times higher mortality than people without diabetes. Because of that, and because of the challenges that faced us all, the other difficulties have been in terms of accessing services. The impact of the coronavirus on diabetes services in primary care and in secondary care has been enormous. People with diabetes have been very worried about going to crowded places or going to places where they perceive the risk of COVID-19 infection as being higher, so primary care services and hospital services. And all these things together, plus the impact of lockdown, have had a significant impact on people with diabetes. We anticipate, I've been involved with a research team globally actually in preparing a paper that's looked at the impact of the pandemic on people with diabetes. We anticipate there will be a significant consequence in the short, medium and long term for people with diabetes. And that makes this recovery piece even more important than it would have been previously. What we hope to achieve is to work collaboratively with our colleagues in primary care in effectively supporting a quality improvement piece to help in particular practices that were more challenged both during and actually before the pandemic. We've triangulated data from a number of data sources, from the National Diabetes Audit, which pulls data from all practices across England and Wales. We've looked at data from achievement in the quality and outcomes framework and those practices who in the past have historically perhaps not achieved as well as they might have done. And we've also looked at data from Eclipse, which is perhaps gives us the best indication of where things are at now. So using all that data together, we've identified practices who we hope we can support in order to help restore and actually build on how we deliver primary care diabetes services now, and actually planning for the future as well. I will stop there and more than happy to take any questions, unless Chris, you've got anything that you wanted to add?
I think only to say, really, we do know certainly, you know, both for type 1 and type 2 diabetes, that's had a massive impact not being able to access service during this time. And certainly that face-to-face contact has been, you know, known. Certainly, I guess, key monitoring hasn't been able to take place, which is crucial for picking up some of the most longer term complications. So certainly where we started with practices that perhaps, for whatever reasons, maybe practices with less resilience, with areas of deprivation, where, you know, checks and processes and outcomes were less, it's really key, I think, to kind of put some targeted support into those now. So really pleased to see this proposal, Claire. So I hope it gets supported.
Thank you. What we would like to do is to use what's known as positive deviance. Positive deviance is a research tool that looks at the best performance in the locality, and what we do is we look to see what are the mechanisms, what are the pathways, what are the things that practices that achieve the best, what do they do, and what do they do that might be transferable to other areas. Now, that's not to say that you can take a model and move it from practice A into practice B and it will work. It doesn't work like that, unfortunately. It's much more complicated, but there are always elements or processes that can make a difference. So what we're hoping to do is work with communities of practice effectively built around neighbourhoods in order to build a sort of mutual support framework in the hope that we can drive improvements and everyone will have the benefit of learning from each other.
Naomi?
Hi, yes, thanks, Claire. That's a really helpful update and put the paper in a bit more context, so thank you for that. We did send through some questions. Apologies for the length of them, but it was the first time we'd seen the paper, so I hadn't been consulted on it prior to this, hence why there were quite a number of areas of clarity. And I think whilst a lot of it is good to support practices, and we fully agree that there are a number of practices that may well need some extra support in this area, it's coupling supporting those practices that need extra support, but also there are practices that have worked incredibly hard to achieve really well in the different diabetes domains with all the pressures of COVID. And so it's coupling in supporting those that have done really well with also supporting those that need extra support. And we just have a bit of concern around the involvement of CDs. For example, it doesn't really fall within the remit of a CD. They're exceedingly busy. They have got 101 requests for their time at the moment. And so it's really around, are they an appropriate resource to utilise? Have they got capacity to do so? We feel it falls outside of their PCN role to be able to support in this, as we've said in our response. And then finally, it's just around, and the report does say this, but I think it's sort of slightly lost in some of the areas, that the targets being referred to are CCG targets as opposed to practice targets. And it's around QoF has been paused as part of COVID-19, and the intention of that was to enable capacity and practice discretion on prioritising care and being involved in the COVID vaccination programme and COVID care. So it's just around where this fits with the pausing of QoF and practices prioritising their care, because they may have many areas of care that all need prioritising. And so it's just around where this fits in with NHS England pausing QoF, of which diabetes has been included in that.
Okay, thank you for your questions. Quite a lot to cover there. So perhaps if I can start with some of the funding and QoF. The reason we looked at QoF is because we recognised that there were challenges because of the pandemic, but actually we had challenges prior to the pandemic. So what we wanted to identify were a combination of practices, those that were most impacted as a consequence of the pandemic, but also those that looked as if they were likely to benefit from support because they were perhaps not achieving in QoF as well as they might have been been prior to the pandemic, and there was a degree of overlap between those two as well. So that's why we've triangulated the different data sources. We recognise that currently QoF is not considered to be one of the priorities, in that it is currently paused, but there will be a need to restore routine care at some point in the future, and there's significant overlap between the requirements in the National Diabetes Audit and those in Diabetes QoF, but there are some gaps. So hence, again, the reason why we've looked at the two different data sources, and the plan is to recover according to what actually represents good clinical practice, which is better represented in the National Diabetes Audit actually than it is in QoF, but everything, or almost everything, that's included in the National Diabetes Audit is actually within QoF. So we perceive that there will be two things. It will help restore good quality routine diabetes care, and it will also help practices build processes that will allow them to better achieve in QoF in the future, as and when QoF is restored. So we think that that will be considered to be a beneficial thing, not just for people with diabetes, but actually also for the practices. What I would hope to do in delivering the Quality Improvement Collaborative is to work with groups of practices clustered by PCN, and it's really because of that that we felt it important that the CD should be informed and aware of what we are doing. And actually many of them were people who were actually party to that discussion with GP colleagues that helped inform the bid at the outset. I don't necessarily perceive it essential that the CD themselves would be party to the Quality Improvement Collaborative. I think that is work that will be with practices, but I think it's entirely appropriate that they would be aware. And again, there may be learning from working with small groups of practices that would likely benefit the PCN and allow the PCN to grow the delivery of how they offer long-term care for people living with diabetes. So again, I think that's just a conduit, if you like. It doesn't necessarily be that we'd expect the PCN CDs themselves to be undertaking the work. That will be largely my responsibility to lead on that as the clinical lead. I hope that answers the questions.
Yeah,
Thank you, Claire, for very informative paper, and actually very clear answers to the questions raised as well. Tracy, did you want to come in?
Yeah, I just kind of wanted to add there, certainly thinking about the role of the PCN clinical directors, and certainly what the asks are of the PCNs in kind of addressing health inequalities, that this is absolutely part of that. So those patients in the ultimate will have very much poorer outcomes if that care and that support isn't picked up again, and certainly it will improve those kind of models to really target this care going forwards, which I think will support those roles, certainly with the requirements of the PCN, DES, inequalities, and the core 20+5 work that everybody will be doing over the coming months and years.
Yeah, I'd agree with that, absolutely, and thank you for raising that, Tracy. One thing that has become very apparent during the course of the pandemic has been the association between missing care processes and inequality, and one of the emerging concerns has been that there does appear to be an association between missing care processes and premature mortality. The team that originally identified that then went back to look at data from the National Diabetes Audit in the decade prior to the pandemic, and we're actually surprised to find that the same pattern was evident then. So it has become apparent that missing care processes, for reasons as yet not clearly identified, but missing key care processes are associated with that increased mortality in people with diabetes. And so Tracy's absolutely right. Recognising this as in itself a marker for inequality, unmet need, and premature mortality is really important, and something that we're really passionate to try and improve.
Thank you. It's really good to see work going on to restore the service, because there's a lot of people with diabetes are concerned that they've missed all these checks in the last 2 years. So it's about patient outcome, and actually sorting this out will be beneficial to the health service in the long run as well. So it's a win-win, I think, for everybody. Can I ask members, if there's no more questions, whether they're happy to approve the papers as outlined by Claire? Yeah, great. Thank you very much, Claire.
Thank you very much. Thank you, everyone, for your time.
Thank you. Right. I need to, is Julian, yes, Julian's with us. So we're going to go back to the health check report on severe mental illness. Good afternoon, Julian.
Good afternoon, everyone, and apologies I was late. Sorry,
No,
but I'm here now.
We were running early, so you weren't late.
Perfect, thank you. Okay, so for those that don't know me, my name is Julian, and I work in the delegated commissioning team. And I'd like to present to you for approval an approach plan to improve the uptake of severe mental health illness annual checks across Norfolk and Waveney. And working on the assumption that the paper has been read by everyone. The ambition for severe mental health or SMI health checks across NHS England and local systems is for 60% of SMI patients on GP registers to have access to their core physical annual health checks. This is an ambition driven by the inequality of access to care for this particular group of patients who are also at higher risk of comorbidities, as well as an increased risk of death due to their condition. Within Norfolk and Waveney, our current performance at Q3 was 28.1%, and this is measured by 6 core metrics that NHS England measures. But as a whole, there is a collection of 11 health checks that need to be completed for quality care to the patient. So 28.1% was our performance of Q3 of this year, and it's important to note that embedded within the paper, historical performance suggests that COVID had some impact on this access of care to the patients, but traditionally our performance has stagnated around the 28.1% against a core metric of 60%. If we adopt a do nothing approach, we run the risk of our performance staying where it is, but it also leaves there's a clinical risk that needs to be described. So within the paper, what I would like to take you through today is to focus on our proposed approach that I would like to gain hopeful approval for from the board members present today. It's a 5-strand approach that we would like to take you through. So I think the first one was the understanding of current data for the SMI patients. We would like to undertake a deep dive into the SMI performance as a whole to understand the barriers of access to care that patients might be impacting, but also from the primary care delivery as well as secondary care point of view, what is causing this performance number to be low and how can we help to resolve it? From October of last year, a small project group has been built up within the delegated commissioning team in very close partnership with the mental health commissioning team to actually look at this collaboratively across the two organizations, if you will. We've also got named nominated leads from the locality teams that we meet on a monthly basis just to gain an understanding and a footprint into what is going on and how can we help to improve. So the first action in terms of understanding the data, there's an action owner of myself and Jenny Lane, as well as a time frame of completion for February 2022 to gain a full understanding of the data and propose some changes that we think will make a difference to it. Action number 2 was the importance of real-time data and availability of dashboards. So liaising with our GP colleagues and gaining some information from them. I think it's important that we actually can identify where the quick wins can be made. So within the paper, I give the example of if a patient, for example, have 4 out of 6 of their core health checks done, the entire health check gets marked as incomplete. So for me, the system is doing a lot of work, but it's just identifying those 2 or 3 health checks that if we do that could achieve completion. Right now, it depends on the practices individually pulling those reports. If we can have more of a closer inspection and grip on that data, we can actually put in some mechanisms in place to develop that a little bit more. Number 3 is undertake a complete stakeholder mapping. So set up a task and finish group. We have commenced that already, but it's more to engage with our wider partners in translate some of the learning that's going on in London, especially that's engaging with charity sectors to help them reach out to even more patients as a whole. And the ultimate ambition and purpose of this group is to gather the local intelligence, review and agree a stringent improvement plan, and hopefully inform and increase performance through each quarter. 2 more points on this approach is the assurance and performance monitoring. I think for me, it would be the team itself needs to be assured that the data that we're looking at is relevant. The changes that we would like to make is actually deliverable before we can give assurance to a group like this. So what we would like to do is work closely with our BI and reporting team to basically marry up the local intelligence with what's NHS England is monitoring us on. One of the asks for me would be how this forum would like to gain assurance of the sustained and sustainable improvement to SMI. Would it be a quarterly update or a monthly update? Initially, I think a quarterly update would marry up with the data that we receive from NHS England anyways, but it would help us to display that we are making our improvements as we go. Lastly, comms and engagement. For me, it would be to circulate the information to GP practices around that this piece of work is going to have more attention. The patient will come first in everything we do. Attend locality practice manager meetings to further raise the profile of work, identify local champions, and embedded within this is a transformation piece. So can we explore alternate methods of service delivery, i.e. one-stop clinics? Could we do virtual checks, etc.? So it's a 5-point action plan at this point in time for approach and approval, but ultimately the aim is to improve access for SMI patients and then improve our local percentage as a whole. So it's a whistle-stop tour, but I'll stop for any questions if that's okay.
Thank you, Julian. Great summary of your paper. Are there any questions? Kathy.
This might come a bit further down the line, but the thing I was thinking as I was reading your paper is that we kind of have an idea of some of the things that this group of service users are going to experience in terms of obesity and smoking, drinking, substance misuse issues. And I'm just wondering if the referral services are there so that, you know, people can come and get their check and then they can actually then progress on to treatment. Because what I was thinking was the thing that was missing in your comms bit was communication with service users. And yet I was thinking if I was a service user and I knew I was going to go to this check and someone was just going to say, yeah, you know, give up smoking, I'd think I'm not sure why I bothered to attend that. But if you were going to give me access to some really useful and supportive services, that may make me more likely to attend and more likely to tell my friends. So I'm just wondering about that part of the process, please.
No, I think that's a really good question. And you alluded it to in the beginning, which was further down the line. So one of the things when I initially wrote this was the focus was on the one-stop shop clinic for me. And I think just listening to some of the conversations that we had in our catch-up meetings, it was this has a scope to cover quite a lot. So exactly what you said, if a patient turns up, has their SMI check, and then we can actually refer them for smoking cessation or health management or weight management, that's a huge win. So completely agree. The other strand to that would be how it might be a bit too far in the making, but just looking at the LD health checks as well as the diabetes annual check. The patient is there in a hopefully clinical environment. This could be extrapolated to all 3 checks, so it's a one-stop shop. So I think this has the opportunity to be translated quite widely. And without going into too much detail, one of the examples from one of our colleagues in London, their centre is built up in a community approach. So rather than patients going to a GP practice, some patients will definitely have to, but the majority were talking about community health centres that could have this umbrella effect of care. So I hope that answered your question, but the point is engagement and comms, it has the opportunity to be explored quite exponentially. So I'll stop there. Tracy, I can see your hand up, but Diane, didn't know if you wanted to back me up on this point.
Yeah, Julian, hi everyone. I'm Diane Smith. I'm one of the senior programme managers of the mental health commissioning team. Kathy, I just wanted to pick up on your point really, because I agree. And from the outset of the health checks, it's the so what. You know, people have their health check, but so what? Absolutely. We've currently got a pilot running with Thrive Tribe to support people, particularly with SMI, to lose weight. So we're piloting that at the moment. And we've just put ourselves forward in Norfolk and Waveney as potentially an early implementer site for smoking cessation focused work for people with mental health needs as well. So I think we are really building on what we can offer in a more appropriate way or adapted way for people with mental health needs, so that we do get the health improvement impact of the health check itself.
Tracy, did you want to come in?
Yeah, I mean, I just think certainly working closely with this kind of group of patients with an SMI, and certainly the challenges of people coming to appointments in primary care, it always doesn't feel the right place to be coming to me. That's what I think time and time again. So really pleased to see you've got some core actions, you're looking at the data and you're thinking about different approaches going forward. So certainly knowing the work with the vaccinations that Together Dan seem to work really, really well, that it's not always, you know, the GP practice that is best supposed to support people to do this, and that we might need to think we're going to people, I suppose, and expect them always to come to us in primary care, because for some communities it just doesn't work. So really keen to see this approach here as well, which I think is great. And I do wonder, you know, certainly I know you kind of said the responsibility sits certainly if people are under mental health particularly, but certainly some people aren't always under mental health, but they might be touching services. It's just making all those contexts count as well. I'm not sure that we utilise that approach as much as we can with those in SMI. And I think it's key, like you said, about having those responsive services around people, because you can tell somebody to stop smoking, that will never happen. You just have something that works, that's targeted and tailored to the individual needs.
No, definitely agree. And I think this is the thing, the more we looked at SMI in isolation, we saw links in quite a lot of core main targets, if you will. Smoking cessation is a big one, diabetes screening as well, LD, SMI, this population of patients making every contact count, I think would be the way forward. And I know, Diane, I know we were discussing the outreach service that the Vaccination Booster Hub did as well. So repurposing that and remodeling it to fit our patients. So this is definitely a really exciting work in progress, but it will be tricky, but I'm here to hopefully give some assurance. Okay. I don't know if I'm allowed Doris to pick, but I'll go Sadie.
Yes, go ahead.
Thank you. I was just going to also mention that following the locally commissioned services review, the SMI locally commissioned service was one of those that underwent quite a lot of change as a result of the process, following some really helpful feedback from LMC colleagues. The majority of the checks are included within the quality and outcomes framework. So we completely changed the emphasis of the locally commissioned service, recognising what Tracy was just saying about how difficult it can be to encourage individuals to access their health checks. So whilst some of the funding is used for the remaining two parts of the health check, the majority of it is now pointed towards trying to build relationships, having somebody responsible within the practice that can try and build those relationships with the individuals and encourage them to attend their health checks. And we'll see how that goes this year in supporting uptake. But of course, there is always an opportunity to do things differently and to change things if they're not working, to encourage, you know, maybe through social prescribing services, for example, different ways of approaching this. But I think we've probably got quite a good start here, which is setting out the broad outline of the plan. And the more we learn through the work that's ongoing, the better we'll be able to shape some of those actions going forward.
That's great, thank you. Diane, did you want to come back in?
Thank you, Doris. Yeah, I just wanted to mention that we're also working quite closely with the digital working group as well, because one of our challenges is around the interoperability and transfer, you know, seeing the data that when somebody's health check has happened, for example, in NSFT across into primary care and going forward. So we really need to make sure that happens so that we can get the best figures out, because going forward it'll only be pulled out of primary care. And that also connects in with opportunities moving forward to implement more point of care testing. So as you say, we don't have to see people necessarily in a more clinical space, but more in a community kind of setting, if we can get that point of care kind of provision in place and linked in with digital work to kind of be able to see the data.
That's great, thank you. It's good to see an action plan, and yes, I'm sure we want to see you come back and give us an update. And I think for me, quarterly sounds quite pragmatic at this stage, and I'm sure you can work that out between the team to get it onto the agenda. So thank you. Look forward to an amazing update next time round.
Thank you very much.
We move on to the finance report, which came out separately. I'm just going to, I think James has joined us. James, do you want to give us a highlight, low light?
Thank you, Doris. As usual, I'll take the report as read, but highlight the key points to you in the report, and also clarify some of the points made. On the executive summary, we can see as at month 9, the total primary care and prescribing budgets are 3.3 million adverse to budget in total. However, this does need to be caveated, as this does include £3.7 million worth of winter access funding budget, which is to be received, which we forecast in full in our position. So therefore, the £3.7 million is not a true deterioration to our position. Moving on to the financial summary page, this shows that the GP prescribing has deteriorated by £500,000 from month 8 to month 9. With the figures being 2 months in arrears, this is an undervaluation of the October estimate. So efficiency savings haven't materialised in this period, putting pressure on the forecast, with our efficiency expectations already baked into our budgets. The forecast has also increased in other areas such as SDF and primary care IT, but there are also increases in allocation awarded to offset this. As we can see, the delegated primary care has increased considerably, but this is to do with the winter access fund that I mentioned previously. So allocation for this is to be received retrospectively and will offset this increase. Moving on to the detailed financial analysis, this shows the key drivers behind the prescribing total overspend of 2.9 million against budget, and some of the areas attempting to mitigate this. Moving into other specific areas of funding, system development fund, we can see in this key area of investment is still predominantly on plan, with a few small favourable variances to budget. Moving into delegated, some favourable variances showing here in terms of the existing ones that we've looked at before, of the Norwich APMS contract, favourable rent revaluations being offset by the pressure within QOF of the 2 indicators that were passed to us from NHS England halfway through this financial year. In addition, again, we can see the £3.7 million worth of WAF costs, which we predict to spend with no current budget, but as stressed, that retrospective allocation will be received from NHS England to offset this. Moving into GP and other prescribing, this gives a detailed analysis of the prescribing cost pressures, offset by some prior year releases from 2021 and favourable dressings and oxygen variances. Finally, in the report on the risks section, there's an additional risk put in there around the national DOAC procurement and what impact that could have on our prescribing finances going forward. So that was all I had in terms of summary. Are there any questions?
Thank you, James. Hein.
Yeah, thank you, James. You mentioned on the detailed variance analysis 2.5 million efficiency schemes forecast to be delivered.
Yeah.
As the end of the year is not too far from us. Is that still realistic?
We are looking to change that in terms of what we've got, in terms of what's been delivered. So obviously the information's often in arrears in terms of what we receive. So we're still looking at some things that the schemes that were set up. Yes, there has been some delivery, and there has been some areas where the regional plans have diverted. So there is a risk there left in the remaining forecast that we've got. Yes, which we need to keep a close eye on.
All right, thanks.
Are there any other questions, James? No, thank you very much for the update, James. We shall see what happens with the prescribing. Thank you for that. I think that comes the end of the agenda for this part one, unless there are any questions that's been submitted by the public whilst we've been gathering. Sarah?
No, Doris, not anything at all.
Thank you very much. Thank you all very much for your time this afternoon. And we are meeting again in March. So I look forward to seeing you all then. For those who are joining for part two, shall we have a 10-minute comfort break and reconvene at 3:15? Thank you very much.